Hello, everyone. Happy Thursday. Welcome to yet another VMR. Today is a all internal affair with the CP Solvers Academy, doing scribing, teaching points, and first-time case discussant. If you're wondering, if you're joining recently or on YouTube, if you're wondering what the heck is this CP Solvers Academy thing, it is a subset of people who join VMR regularly who are super passionate about clinical reasoning. And it's a community that's even tighter than the VMR community, full of people that you will meet shortly. I highly, highly encourage you, if you like coming to VMRs regularly or like watching them on YouTube, to think about what it might look like if you were part of the team. And the pathway is very simple. Just come hang out in VMR as much as you're able to. Turn your video on and make your presence felt. And one really effective way to make your presence felt is to present cases. And the good news in that domain is that we help you put cases together. And so I'll show you. If you go to the main website, theclinicalproblemsolving.com, and you click on morning report, you go down, helps you present a case, and we connect you with one of these amazing team members to walk you through the case presenting process. You get to hang out with these bright minds and share your love of medicine with us. No case is too simple for CP Solvers. I promise you that. Yesterday in the academy, we talked about a very simple case of heart failure and atrial flutter, and talked about how complex that was. So we hope you think about it too. But I've rambled enough. I'm very, very excited to tell you that our discussant from last week is slotted into the scribing role today. Mukund, thank you so much for doing that. One of our newest members, who is now in month 4 or 5, Hugh Moon, is doing the teaching points today. Case presenter extraordinaire, Yuki, is back. And I'll hand the mic to her in a moment. But it's a special, special day because it's our beloved Parisa's first time ever discussing. And yeah, it's been amazing to see Parisa grow and shine. I still remember the conversation that I had with her when she was joining the academy about this very moment. And I think it really culminates a tremendous amount of impact that she's had in this space. She's actually one of the newest members of the case review committee. So if you do submit a case, there's a decent chance you might be paired with her to review a case. But with Parisa, very, very excited to discuss with you. I'll hand the mic to you to say hi, and then maybe we can hand it to Yuki and then jump right in.
Hello, everyone. My name is Parisa. I'm super excited for this today and Yuki's case. It is my first discussion, and let's rock and roll.
Can you make me co-host?
Oh, for sure. Sorry about that. Oh my gosh. Yuki, do you want to say a quick hello before you present the case?
Okay, thank you for having me here as a presenter many times. I'm Yuki from Japan, and now it's 10 p.m.
Oh my gosh.
like as usual.
Yeah.
And I'm really excited to present here as always.
Wonderful, Yuki. Well, I think we're ready whenever you are, and we'll jump right in and learn together.
Okay, I'm gonna start. Okay, so today's case is a 65-year-old female presented to clinic due to 1 week history of right flank pain. 1 week prior to the visit, she noticed a tingling pain on her right flank, which was very similar to the herpes zoster she experienced in the past, she said. Regarding her pain, patient reported 6 out of 10 pain can get up to 10, and sometimes made it difficult for her to sleep at night. She described the onset as gradual, with no other associated symptoms, and noted that the pain did not radiate anywhere. Patient tried a heating pad and ibuprofen with minimal improvement. The pain worsened with neither exercise nor deep breathing. Okay, this is the end of HPI, so I'm gonna stop here.
All righty, amazing. What an intriguing start. Parisa, I'll tell you that what I heard is this is a 65-year-old woman, and the conversation is going to be centered around, actually, let me clarify. Yuki, was it her foot or her flank?
Right flank pain, so
Yeah.
like this here.
Gotcha. Yeah. So it's her right flank that's hurting her. And the pain has been really bothersome. It has a tingling quality. And interestingly, we learned that she's had herpes zoster before. And it feels similar to that. But I think it's pretty clear that the big picture here is flank pain. And so I'm curious, Parisa, in your experience and learning, we often start our thinking by the base rate, like what are common things that cause flank pain. So even when you don't know any more details about the presentation and you just know flank pain, what reflex diagnoses start to come to your mind?
I think the first thing is coming to my mind after hearing the flank pain is kidney compartment, anything related to kidney. And it could be, for example, it could be pyelonephritis, and it could be anything related to whatever is involving any retroperitoneal compartment, and specifically kidney.
I love that. I think you're jumping into the weight of flank pain as in kidney. And but you're realizing the general compartment of retroperitoneum is really what you're thinking about. What's really interesting about the kidney, Parisa, if we talk this through, is there are many kidney issues that are painless. So for example, acute kidney injury, ATN, pre-renal AKI, there's not much pain involved. So if we were to try to, me and you together, to be like, what kind of kidney issues result in pain and not just kidney dysfunction? How do you think that through?
I would say any kidney infection that it will expand the kidney parenchyma would lead to kidney pain.
Yeah, 100%. I think you said the key word, which is that the renal capsule has to be under pressure for the kidney to hurt. And that is often because of a plumbing issue, either a obstruction in the plumbing of the ureter, or less commonly, an obstruction in the vascular inflow, i.e. a thrombosis that causes ischemia, infarct, and stretch of the kidney capsule. So whenever you're thinking kidney pain, it's much more likely to be a plumbing issue rather than a parenchymal issue. But a parenchymal issue such as pyelonephritis or an expanding RCC can do it. And so I think that's where we would be at right now, is to think, okay, flank pain equals kidney. It is actually also very common for musculoskeletal causes to cause flank pain. So I actually had this when I had a cough. I coughed, and I pulled my flank muscle. And so the tension in most cases is it at the surface in the skin or the muscle or the bone, or is it deeper inside, like in the kidney? So if you were to try to think through what might help you think that the problem is on the surface, like the muscle, and what might help you think the problem is deeper, what parts would you be suspicious that there's a deeper problem?
I think the regular thing we have in physical exam is severe anger tenderness could help us to distinguish is it deeper or not. Or for example, if it's the pain is exaggerating with any movement,
Yes.
maybe we could link that with any musculoskeletal compartment.
Excellent. The pain with movement is so key. If it hurts when you move, it's probably not deep on the inside. And the best example of this phenomenon is patients with kidney stones. Patients with kidney stones are moving all the time. They're so restless. I can't imagine if that's the same patient who has a muscle spasm or a broken rib, they're going to be sitting still. So I think that is a very, very key observation. So excellent. So we're like, the first pass is MSK or surface versus renal, but we already said that the other pass is retroperitoneal. I'll just emphasize that the lungs can also go all the way down to the flanks. So you can have a empyema or a pleural process cause flank pain. So there's really in the world of flank pain, we think about common first, surface or kidney. And then if we don't find anything at the surface or in the kidney, we expand our gaze to the lungs and the retroperitoneum. So if we use that template here, Parisa, what now you can sort of think about the HPI as a whole. Where is the HPI as a whole taking you? What do you think? What other features here are making you go one way or the other?
Which part of the HBI is taking me?
Yeah, so we have here that it's been 1 week, it's tingling, it's keeping her up at night, heating pad didn't help, deep breathing didn't make it worse. How do you use those things to help you make a guess where this problem is? Is it surface, kidney, retroperitoneal, or lung? What do you think?
I think when we are hearing that heating pad, it's not helping, which means that it is not musculoskeletal and it is not on the surface. When we are hearing that deep breathing, it's not exaggerating it. Probably it's not related to the lung.
Excellent. Superb. Agreed. How are you incorporating the tingling?
I'm usually, for me, tingling is connected to any nerve compartment, and it is similar. But when she says that it is not similar to the time she had the herpes zoster, it is the disconnect for me. But usually tingling for me is connected to any nerve issue and problems.
Yeah, I think you can, when moving doesn't make it worse, you can exclude surface problems, but the problem you might have to include is nerves, because nerve problems may not be affected by moving. Think about neuropathy, for example, and tingling. So I think that the only prominent clue we have here that should help us deviate from the base rate is this actually a neuropathy? And I think that's a question we can try to explore in parallel with exploring the whole schema, but we'll see if that lead takes us anywhere. So to summarize, I think renal pain, think plumbing, flank pain, think surface and kidney first. If you want to be thorough, don't be thorough until you've ruled them out, but the world includes the lungs and the retroperitoneum. And I think in the world of MSK issues, pain with movement is really, really helpful, but that may not help you pick out a abdominal neuropathy. And so that is one lead we'll follow here. Awesome. Any other thoughts you wanted to share that crossed your mind before we hear more information from Yuki, Parisa?
No, the only thing is coming to my mind that it's I know that there are some variable of that herpes zoster that it is that they do not have any rash. I cannot recall the name directly. I think sin herpeti,
Yeah.
but they have the neuropathy, but they do not have the rash.
Exactly. No, that's a very, very interesting thought. We'll see if it bears fruit for sure. All right, Yuki, what do you have next?
Thank you very much for exciting discussion. I really love them. Okay, I'm gonna review the additional information. Past medical history included medically controlled hypertension, hyperlipidemia, on herpes zoster on left lower back at age of 50. She denied any surgical history. Medication-wise, patient was on losartan, 25 milligram one tablet once daily, on atorvastatin, 10 milligram one tablet once daily. There were no newly prescribed medications in the past year. She had no allergies. She had lived with her husband and worked as a farmer for over 40 years. A lifelong non-smoker and drank alcohol only on social occasions. Denied any use of recreational drug. Denied any recent strenuous exercise. except for farming. No pets, no apparent tick bites, no exposure to farm animals, no recent injuries at all, no recent travel in the last 6 months. So would you like to move on to the next argument, or what do you think?
Yeah, Yuki, I'm really curious. Parisa, do you think there's anything here that influences your thinking in a prominent manner?
Not honestly. I
Yeah,
think
no.
it's
Yeah. I think it goes to show you that when people present with pain syndromes without dysfunction, meaning that there is no consequence to this problem yet, apart from discomfort to the patient, it's so hard to make progress without seeing what the physical imprint on the patient's body is of that discomfort. So if you just hear headache and headache alone, you don't know if the lung cancer history is going to be relevant or not, because tension headaches are very, very common. But if you see headache plus organ dysfunction, like weakness, then all of a sudden the medical history becomes very rich. I think it's not surprising that a pain predominant HPI does not allow you to make progress until you see the imprint of the pain syndrome on the patient's surface, or if you're so inclined based on some features to investigate it and understand. So in summary, I think we have to update our problem representation from pain to something more specific, like pyelo, to then be able to use the medical history to our advantage. It would be very, very hard to make any progress on a pain predominant syndrome. So I think our focus is, can we find something in the foreground on the exam or on the labs to color the story more than just a pain issue? And I'm excited to see what Yuki has in store for us.
Okay, I can go to physicals. Vitals, body temperature, 97.7 Fahrenheit, 36.5 Celsius, heart rate 88, regular, respiration rate 12 per minute, blood pressure 133/88, pulse ox 98% on room air. Vitals were normal. On physical examinations, patient was awake, alert, but not in acute distress, and no abnormalities were noted on HLT, cardiopulmonary, abdominal, neurological exams. So there was no severe tenderness at this moment. And musculoskeletal and skin exams showed that the exposed skin was normal with no lashes or lesions, but there was slight redness without blisters on the right flank, and no tenderness was noted on the ribs. Okay, this is the end of our physical exam. So what do you think, Parisa?
Gosh. So Yuki, it sounds like the only abnormality is that there was some slight redness where she was hurting. Oh, interesting. Parisa, what are you thinking?
I think we need to start. We need to simplify that problem for myself. The
Yeah.
thing is, patient is not febrile. I'm not thinking about any pyelonephritis, because the pyelonephritis with that flank pain and prolongated for 1 week probably has a prominent severe anger tenderness. Now I'm facing a patient with right flank pain with normal physical exam, just have a redness on her right flank. I'm thinking of maybe some infiltrative problem on the background, but I think I need more lab data to incorporate it to the physical exam, but I'm not able to anchor to anything at this point.
Yeah, me neither, Parisa. I don't think I've ever seen anything like this, and I'm so intrigued by it because Redness on the skin in a localized distribution often means a localized skin infection like cellulitis, or exposure to an irritant like contact dermatitis, or in some areas reflective of venous stasis. And the three most common causes of skin redness here, infection, irritation, and venous hypertension, are not at play based on the location of this condition. And so I find it very intriguing both that the redness on the flank would be a highly unusual thing in general, and that the pain described by it is of a neuropathic quality. And so this is a very interesting combination of both a problem that seems to be at the surface. The skin is red. We might be at risk of over-exaggerating the skin redness because the patient is telling us that it's hurting there. And the skin redness may merely be the result of her rubbing it and irritating it because she's in pain. And so I would struggle in real life to know what to do and to say, this has been stable for a week. Should we just give you some pain medications like NSAIDs or topical medications and discharge you and not need further investigation? And so I find it really, really, it's going to be very cool for me when we reach the case conclusion as to why this case is obviously different than just treat symptomatically and see what happens, because obviously there's a little bit of a twist to it. But I would just say that for most people who have 1 week of a static syndrome of pain in their flank, who don't have nausea, vomiting, vital sign abnormalities, and the only thing you can find is a little bit of redness, I don't know how many of those people deserve a very thorough, meticulous evaluation. And most of them probably will never know what they had, but they get better. And so I am right there with you. I'm very, very intrigued, very, very puzzled, and would be at risk in real life of not even getting that labs. So I'm really, really excited to learn from Yuki. It's a very it's a very not Yuki presentation. Most of Yuki's cases are the patient's so sick and they have Klebsiella everywhere. This is like, what's the problem here, you know? So we'll yeah, let's see. Did you have any other thoughts you wanted to add before we hear more from Yuki?
Yes, I'm trying to link the other schema we have. There is no history of active cancer. There is no history of trauma. There is no history of glucocorticoid using. There is nothing else that I could link it to this current presentation. I'm trying to find any red flag and finding anything that I'm trying to decide that should I keep this patient. I'm trying to write anything is happening from now on that I need to make any intervention, but I'm not able to find it. Really excited to learn from Yuki.
All right.
Okay. Thank you very much for sharing your thoughts. I also learned a lot through this fantastic discussion. Okay, I'm gonna start with initial workup. Blood test, CBC showed red blood cell count 3.2, hemoglobin 12, platelet count 202,000, chemistry, sodium 141, potassium 4.4, chloride 11, BUL 19, creatinine 0.2, 0.72, LFT, AST 36, ALT 26, ALP 117, LDH 308, CK 133, albumin 4.4, and CLP was 0.05, which was within normal limits in Japanese vaginal units. So at this point, everything appeared good except for white blood cell count, LDH, and ALP. On chest X-ray was unremarkable.
Thank you so much, Yuki. I just want to make sure we have we're analyzing your, so the abnormalities are a low white count, a slightly high LDH, and then there was one more thing that was abnormal, you said? I missed that. I'm sorry. And alpha.
Yeah, of course. Yeah.
Okay, all right. Very, very interesting. Yeah, Parisa, I'm curious, which of these three things that are in red is jumping out to you the most and that you're inclined to analyze first?
Thank you, Yuki, for giving us more information. I think the first thing it's catching my eye is LDH. For me, I learned that for approaching the LDH, I need to first rule out the no misdiagnosis, which is hemolysis and rhabdomyolysis, and then I need to come to that organ-wise. I need to think about acute liver failure. I need to rule out any pulmonary problem. I need to check kidney problem, and then if there is none of those, I need to think about any malignancies. And I think the malignancies might be play a role here. And I think also because the alkaline phosphatase is elevated, maybe we could link it to some bony compartment and also some, this is one arm, the other arm also is some kidney problem because LDH is also elevated. But on the other hand, white BC is slightly low, maybe some lymphoproliferative problem is in the background. I think I need your help.
Yeah, no, I don't know if you need my help. I think that's absolutely superb. I think your LDH schema is awesome. And I think the way you're translating the alk phos is very, very wise. I'll just say that, you know, in most instances, Yuki's highlighting these laboratory abnormalities, but their severity is extremely mild. Our white count is normally 4. Alk phos in my lab, that would be normal, 117. Above 130 is abnormal. And an LDH upper limit of normal is 290. So I think the biggest question in real life would be, are these of any significance? Or are they merely minor standard deviations from normal in a patient without a high-risk phenotype? And so I think the tension would be in real life, do we investigate these further? Or do we say that these are actually close enough to normal that the patient should be given symptomatic therapy? And of course, if the patient doesn't improve with symptomatic therapy, you would repeat these labs and see if they turn into signal. But right now, the signal to noise ratio is very, very complex. It would be very different if the LDH were 500 or 600, or very different if the alk phos were 300 or 400. So I think this in real life would be a case of, well, what do you need to do bare minimum in a case like this? And I think bare minimum, I don't think you need to get any extensive investigations, but anytime you have leukopenia, anytime you have it, you really have to think that could this person have HIV? So an HIV test should be a reflex test in a patient with leukopenia. And I don't think you need to do anything else in a patient with mild leukopenia except an HIV test. I think an alk phos like this and an LDH like this don't need thorough investigation, but in a patient who's having pain, you might consider getting an X-ray, as Yuki did, to see if there are any obvious lesions seen in the ribs. So I think the tension in real life would be, of course, get an HIV test. But do you then follow this up with imaging to look for the hepatic or bony signature of this disease as evidenced by the alk phos? Or do you let it play out for some time and see if the patient will improve and these laboratory abnormalities are noise, or this case declares itself more overtly? So I think you were teaching us such a powerful principle with this case, which is in every other VMR I've ever been to, it's been very obvious that the patient needs more workup. But I would just outline authentically that in a case like this, it would be the decision tree would be, should we watch the patient clinically or should we investigate further? And I want to emphasize that watching a patient clinically and seeing how their syndrome and their labs evolve is not a passive dismissive exercise. In most patients, it tends to be the most powerful variable you can use. And if somebody spontaneously improves without directed treatment, that is a more powerful clue than any other test you can think of. So if I were taking care of this patient, I would probably get an HIV test and then ask her to try symptomatic treatment for 1 to 2 weeks. And if she's better, we're done. If she's not better, then we've gained a tremendous amount of momentum to move the case forward. But speaking of move the case forward, Yuki, what did you all do?
Okay. At this moment, we also didn't have a full picture of this condition. But our differential diagnosis included prodromal pain or herpes zoster or synucleinopathy, like Parisa said. So herpes zoster without blisters. So we prescribed acyclovir, pregabalin, on the plan the follow-up visit in 1 week, consulting CT scan of the chest if the symptom persists. This patient didn't have any concerning sexual history. This is kind of usual in Japan. So we didn't do any HIV testing for this patient. But 1 week after discharge, she experienced exacerbation of the pain and came back to clinic. Yes, this is the end of Aliquid 5.
And Yuki, wonderful. Do you have how many more aliquots do you have until you are finished?
Next Aliquid will reveal the diagnosis.
Ooh, are you ready, Parisa? I'm not.
Me neither.
What are you thinking?
I'm thinking when now the pain uh, it's not equal with the hemodynamic of the patient, and it is weird for me. I cannot link all the scenario with I cannot link everything together. The only thing it's coming to my mind, I can't think about any nerve problem, any neuropathies, any neurology compartment. I don't know, maybe in the context of infiltration and anything it's happening in the retroperitoneum, any nerve entrapment. Honestly, I don't have any clue.
Yeah, I completely agree with you. There are many instances in real life where we recognize that there's so many things under the abdomen and the retroperitoneum. Sorry, under the abdomen or the retroperitoneum, and so we get a scan to really try to figure out what is really under there. And I think that that's the key decision here, is when do you take a look? And I think that your ability to take a look now and really make progress has been enlightened by the fact that she's still symptomatic. I'm really curious, Yuki, do you know, does she still have the slight redness when she represented, or did the slight redness go away? I'd be really curious to know when you were when you were thinking of that.
At this moment, she still has slight redness on the affected region.
I see. Yeah, I think that's the tension, Pri says. Do we include that in our problem representation or not? And I think that the reason that I'm having difficulty is this a nerve problem? And is the insight into this nerve problem the fact that she has a slightly elevated alk phos and that she might have a bony problem compressing on her nerves? Or is this actually a skin problem? Yeah, I would have a very hard time making a tremendous amount of progress here. I think the range of possibilities are that she has a bone problem, such as Paget's, a nerve problem, such as radiculopathy. But I think it is very telling that her pain has not progressed to some kind of disability or dysfunction. She hasn't lost her ability to eat. She hasn't lost her ability to walk. She hasn't lost her ability to talk. And so I find that very intriguing. I wouldn't have any clue what to expect on the scan, but I think bony things are opened by the alk phos. Nerve things are opened by the character of her symptoms. And I think I wouldn't be surprised if her scan is negative and this is a presumptive diagnosis. And then the tension would be, oh, should we get an MRI to see if there's some form of thoracic radiculopathy? But that would be very tricky. Any final thoughts you wanted to throw in, Parisa, before we hear from Yuki?
When you are talking about Paget, do you think, for example, someone at this age could be the first presentation? And
yeah, Paget's disease of bone is really fascinating. There are many different kinds of Paget's, but that of the bone typically presents in middle age. So this would be a very fair game presentation for it. And it's described by characteristic lesions in the axial skeleton. And it may be painful or painless. The alk phos may be normal or through the roof. So yeah, this patient's age is compatible with Paget's disease. And it would explain the very mild perturbances of the laboratory data. All right, Yuki, what did you all find?
Okay, so thank you for final discussion. And I'm gonna go through the imaging test. Chest X-ray without contrast showed a mass extending into the spinal canal from the right T2 and T3 intervertebral foramen. Chest MRI was added, which showed a tumor was extending from the epidural space in the T2 and T3 spinal canal to the vertebral region involving the vertebral body, vertebral arch, and wheels. The T2 weight image showed high signal intensity and significant diffusion restriction, whereas mild heterogeneous enhancement resulted from an early stage. And this patient was sent to a tertiary care hospital. And finally, a needle biopsy confirmed malignant lymphoma, B-cell diffuse large cell type. And the patient underwent chemotherapy and radiation there, but the final diagnosis was poor. Yeah, this is the end of this case. And yeah, this case was challenging to manage and diagnose correctly. Yeah, this was like real life aspect of medicine. So sometimes patient presented with vague symptoms or atypical presentation in a busy clinic. I brought here because I thought it would be a fantastic case to share with you all. Thank you.
Absolutely fantastic case. Yuki, I'm glad we finished a little early because we can sort of reflect on what you found and found as a very challenging thing. Yeah, Parisa, what are your thoughts?
Amazing case, Yuki. Thank you for sharing it with us. Lymphoma could be really tricky, and it is messing with us, could be really silent. And I learned a lot. Thank you so much for bringing it to us. Thank you.
Yeah, maybe I can just take a few moments to say I'm glad we finished early to explain the initial diagnosis. Yuki essentially diagnosed a compressive radiculopathy. The patient had no motor weakness and had a radiating pain syndrome, which is consistent with a radiculopathy, and that can be sometimes confused with a myelopathy. So if you think about the spinal cord encased in the vertebral canal and the nerves exiting the spinal cord out to the body. A myelopathy is a condition in which a process is compressing the spinal cord itself. A radiculopathy is a process that causes compression of the nerve roots as they exit from the spinal cord. In a patient who has a myelopathy, immediate imaging is done in the emergency room for these patients because their cord is compromised. This case is a classic presentation of a radiculopathy with numbness, with tingling that is going out into the periphery of the body. The distracting feature here was the overlying skin redness, which was very much likely the result of the patient rubbing and manipulating the area. And the clue was how much more uncomfortable she was than the rash. It is also possible that the patient has tumor in that area of redness, a phenomenon called zoster-reform metastasis, where tumors can extend along the nerve that they are implicating. And this is classically described in melanoma, but can also occur in other cancers. And so the question is, when you have a radiculopathy, what is the most common cause? It depends on where your radiculopathy is. If your radiculopathy is in the neck or in the lumbar spine, compression from chronic degenerative disease of the spine is about 99% of all causes. And that's especially true when the patient's radiculopathy does not progress into a myelopathy. If you have a sinister process initially developing as a radiculopathy, like a cancer or an epidural abscess or an infection, very soon after the development of radicular symptoms will the syndrome progress and start to take up more space in the spinal canal, resulting in a myelopathy. So how can you decide who needs a workup for a isolated radiculopathy? And the longer that the radiculopathy lasts and remains just a radiculopathy, a pain syndrome, the more confident you can be that the patient has a non-progressive cause of their nerve root compression, and the probability of that evolving into a myelopathy is very, very low. So if a patient comes in and tells you, "Hi, doctor, I've had numbness and tingling in my arm or my leg or even my flank for months," and then you say, "Oh, wow, you've had that, but it has not advanced to compress the cord or other nerves," you probably have a static, slowly progressive disease process. It's very likely to be a compression by the bone or an indolent tumor like a schwannoma. And so we can, slowly get a workup and maybe get imaging. So when is that rule broken? That rule is broken, of course, when a radiculopathy progresses either to multiple radiculopathies or progresses to a myelopathy. That's one way, progression of radiculopathy to other forms, a polyradiculopathy or a myelopathy. And to emphasize polyradiculopathy, cauda equina is a polyradiculopathy. It's multiple nerve roots that are compressed in the same location. The other feature, of course, is a radiculopathy associated with a systemic syndrome. And the best example of that is a radiculopathy associated with the development of a vesicular rash, i.e. zoster. So there are other forms of non-DJD radiculopathy, and the most common is an infection of those nerve roots by herpes zoster. And unfortunately, this case was very tricky to diagnose because the patient has a static, slowly progressive radiculopathy and has potentially zoster based on her history and the rash. It's very easy to invoke zoster. But what is the major clue that she has an unusual cause is that the radiculopathy is in the thoracic region. It's very, very unusual to get compressive radiculopathy in the thorax. Very, very unusual. But the problem is, in this case, the most common location of herpes zoster reactivation is in the thorax. So the tension at moment number one is, does this patient have zoster? And I think it was a very wise move to treat her for zoster and see what happens to her. Because if you image everybody with thoracic radiculopathy who has zoster, you will over-image people for sure. But when her pain worsens, you are now left with, does she have post-herpetic neuralgia, or does she have a other form of radiculopathy, either a progressive compressive form or other forms of radiculopathy like infection with Lyme disease or infiltration by sarcoid, and even diabetes can cause a non-compressive radiculopathy. So this patient, if not caught early, would have definitely developed polyradiculopathy or myelopathy, at which point imaging would have been done ASAP. So Yuki and her team, in my opinion, delivered outstanding care, catching a lymphoma in its radicular phase. It's very, very hard. And the clues to pursue it, I don't think were the labs. They were very mild. The clues to pursue it where the patient had no longer had good evidence for zoster, which is the most common cause of thoracic radiculopathy, and still had pain in that area. The other major clue I would emphasize, it is very unusual, absent immunosuppression, to have zoster twice. Unlike HSV, VZV is not a recurrent disease in most people. When people have HSV, recurrence is the norm. When people have VZV, recurrence only happens in 5% of patients. So if you reanalyze this case and do a cognitive autopsy, the rash is a distractor. Recurrent HSV is rare. Recurrent VZV, excuse me, is rare. So those are the things that you might use to argue, as Yuki did, to get extensive imaging in this patient, which was very wise. And you can see that this patient was going to have other symptoms because look at that CT read. Mass extending into the spinal canal and the intravertebral foramen. That spinal cord is going to be compressed any moment now. And I think catching it sooner is a heroic act. So I'll summarize. Radiculopathy, a problem with the nerve roots exiting. The most common causes are compressive diseases in the cervical and cervical and lumbar spine, usually chronic and long-standing. There are other forms of radiculopathy that are either aggressive compression that quickly evolves into a polyradiculopathy or a myelopathy, and non-compressive diseases, of which HSV is the most, VZV is the most important. Start to think about non-compressive causes or aggressive compression if it involves the thorax. However, VZV is the most common cause of a non-compressive radiculopathy in the thoracic spine. So if there's any hint of VZV, treat that and see if the patient improves. And your hint might be that there's a rash, but that counter argument may be if the patient already has VZV, it does not come back. Absolutely mind-blowing and incredibly educational case. I've spoken a lot, Parisa, since we had some time, so I'm curious if there's anything that was ambiguous or unclear about any of that.
It was really amazing. I recall that one of the cases I brought in. Did you remember it was a woman, she presented with back pain and weakness, and the back pain ended up to be a herpes zoster, and the final diagnosis was therapy-related AML. I think it is really linked. All these zoster presentation, we need to deep delve and keep the patient under close observation. What will happen eventually? Maybe some lymphoproliferative disorder is happening in the background. Really grateful to you, Yuki. It was a great and amazing case. Thank you so much.
Yuki, I'll share with you on a personal note. I know people who've had this presentation who had a 6 or 7 month diagnostic delay. And so you're catching a lymphoma this early and seeing it and removing the camouflage of, oh, just a little bit of radiculopathy is outstanding medical care. And to be able to do so in such a busy setting is really, really powerful. I think this is one of those unfortunate circumstances where a deadly disease comes and sneaks under something very, very common and hides under something very, very common. And I think that the prior history of zoster making recurrence less likely and the lack of an overt vesicular rash were great reasons to pursue aggressive testing in this patient. It becomes even harder if her radiculopathy is in her neck or her lumbar spine, where it's even harder to suspect this diagnosis because the compressive causes are so much more common. So really, really massive kudos to you. It's amazing. Parisa, it was such a delight to discuss with you. Your equanimity and composure and thoughts were superb. I already look forward to the next time. Unfortunately, I have to head out to make it to work on time, so I will pass the mic to the one and only Himun, who I just made you host, Himun. So please feel free to end the meeting whenever you're done. Thank you again, Yuki. Really, really enjoyed it.
Thank you so
Sure.
much. Thank you, Parisa. Okay, Yuki, amazing presentation. Thank you so much. Parisa, you did a wonderful job. I learned so much. Thank you so much. And I will start the teaching point. 65-year-old with a right flank pain, tingling quality with the past herpes zoster, and how to significant right flank pain can we approach? We have to look at the deep force surface, like deep kidney with the pain, vascular obstruction, example thrombosis, stone, and the parenchyma is usually painless, but a renal carcinoma we can consider, and also a muscular issue we can do the by movement, and also lung and retroperitoneal issues. And this patient had tingling nerve irritation, so we have to consider about neuropathy. Pain with just omnipredominant pain syndrome, we have to look at a physical exam and a lab result to further look at it. And the patient's skin redness is related with infection, irritation, and venous hypertension, or maybe this patient was due to the stretch. And the lab result showed only mild leukopenia and mild elevated LDH and mild alkali phosphatase. So we consider whether should have a further investigation or symptomatic treatment is enough. But if a patient is symptomatic, like having skin redness and compressing the nerve and like this patient, then abdominal CT scan and previous herpes zoster, then it's necessary to have abdominal CT scan and MRI to look at the further to look at the abdominal and retroperitoneal issues. And the patient CT MRI showed a tumor extension affecting the spinal canal and all involvement with the vertebral body and arch, leading to localized pain and nerve compression. Rabih mentioned that there will be a myelopathy and radiculopathy. Myelopathy is necessary to have immediate imaging for spinal cord compression, and radiculopathy for this patient, nerve root and tingling was seen. And for this patient, treating the VZV was really a good choice. And then it is really always look at the patient carefully and further investigation for this patient. Thank you. Thank you. We'll end. Well, thank you for everything, and see you tomorrow.